Oh, gosh. Okay, we are live. Okay. Good morning. It is January 12th. Time flies, and this is Senate Health and Welfare Committee. So good morning. This morning we're going to look at two bills. One's a little bit longer than the other. So we're going to start with the shorter of the two bills, and it is an act relating to Medicaid coverage for doula services, and we happen to have the lead sponsor here. So Senator Gulick, why don't you?
I will start us off, you bet. And Senator Gulick, I guess I don't have to speak to the record, right? Because I'm here all the time. So
You'll say your name for the record.
Okay, Senator Martine Laroque Gulick from Chittenden Central, live in Burlington, and thank you for letting me speak to this bill today. This is a simple bill, and I think it's a happy bill because it's such a positive part of our, hopefully, medical system in the future. It's a bill that would require Medicaid coverage for doula services during labor, birth, and prenatal and postpartum periods. And the reason that this bill spoke to me and I felt like I wanted to support it was that I was very fortunate to have doulas for both of my births. And the reason why I really wanted a doula at the time, and this is now, almost 27 years ago, was that I had no family in the area. I was working full time and I had a partner who traveled constantly. So I was basically alone, and I felt like I really needed support for a journey that was unknown to me, something I had never done before. So I was fortunate to have the means to pay for a doula myself, and it ended up being just an absolutely incredible experience. And I ended up, for my second birth as well, hiring the same doula to be with me through that experience. So that was where my desire to support this bill came from. And then after the fact, I started learning more about doula and health outcomes, and it became really clear to me that this is something that can have a huge impact on not only the health and welfare of a mother and a baby and an infant, but also, in terms of economy, this ends up being something that's really, really worthwhile. When a woman has agency over the birth experience, outcomes tend to be much more positive. There's less medical intervention often, and thus less expense at the end of the day. So this is a bill that will pay dividends in many, many ways, and I hope that we can pass it.
Okay, thank you. So I think for folks who don't know, perhaps you could tell us what a doula is exactly.
Okay, yes. So doula is the etymology is that it does come from Greek, and it is, it's not a doctor, not a nurse, not a midwife, but someone who has training and experience in supporting a woman and potentially also a man or anyone who can give birth through the process before birth, taking courses, getting up to speed on everything there is to know about what a birth experience might be like, and then being sort of on call and present the day of the birth. And for my case, it was days. It wasn't just one day, several. And then afterwards, supporting with everything from breastfeeding to just managing pain, etc. So it's someone who really takes you through the entire journey. And, we stayed friends for years and years and years afterwards. So it ended up being a really lovely relationship, which is important.
Nice. Questions for Senator Gulick? Okay, so Jen, why don't we walk through the bill briefly, and then we can, unless I hear differently, we'll put it up on on the agenda at some point for testimony.
Good morning, Jennifer Carvey, Office of Legislative Counsel. I was going to start out with a little overview of what a doula is, but I think Senator Gulick did such a great job, I don't need to do that, so I'm just going to go with it. This is S-109, an act relating to Medicaid coverage for doula services. This would add a new provision in Title 33, directing the Department of Vermont Health Access to provide reimbursement to a qualified doula for providing childbirth, education, and support services, including physical and emotional support, to individuals who are covered by Medicaid during pregnancy, labor and delivery, and the postpartum period. It would require the department to maintain a registry of qualified doulas who meet all of the requirements in the next subsection and are entitled to reimbursement under this section. And doulas, it specifies that doulas would not receive reimbursement for travel time or mileage expenses. In order to appear in the registry of qualified doulas and receive reimbursement from Medicaid, a doula must meet the following requirements. They must receive and maintain certification by an approved national certification agency identified by the Department of Vermont Health Access, DVHA, by rule. And we'll look at some of those in a moment. They need to obtain additional training at their own expense focused on doula care for special populations, on becoming a Medicaid participating provider, and on such additional topics as the department may require. They would need to submit to a background check and fingerprinting and maintain personal liability insurance. Section 2 is a rulemaking requirement directing the Commissioner of DVHA to adopt rules to implement the provisions of this act, including at a minimum specifying a list of the organizations from which a doula may receive certification in order to qualify as an approved doula, to be on that registry list. And there's a list of several existing organizations that do certify doulas that would need to be included on that list. And then also the rules would need to specify the coverage available for doula services per pregnancy, regardless of the number of infants involved, which would be billed on a fee-for-service basis, up to, not to exceed $850 and allocated as follows. So $25 an hour for prenatal visits, not to exceed 4 hours. A flat fee of $650 for physical and emotional support for the entire course of the mother's labor and delivery, including unlimited telephone and email contact, and the doula's commitment to be available on an on-call basis. $25 an hour for postpartum visits, which may include postpartum hospital visits, not to exceed 2 hours, and then up to $50 for administrative expenses. It would allow the commissioner to propose increases to those amounts over time as appropriate. Section 3 directs DVHA to seek a state plan amendment from the federal government if needed to allow the Medicaid program to provide this coverage for doula services. And the bill was introduced last year, so it has currently an effective date of July 1st, 2023. That would need to be updated. Or upon approval of a state plan amendment, whichever is later, but it would allow the commissioner to start the rulemaking process earlier in order to ensure the rules would be in effect by the effective date of the act.
So just Medicaid?
This is just a requirement for Medicaid coverage.
So what about people with personal?
Private insurance, that would be up to the private insurers, whether they cover it or not. I mean, we could mandate it, but that'd be a different move. Is there did you figure out any kind of a fiscal note for this at this point or not?
I do think no one has looked into this in the past, so
Yeah, I
we
think
have
so.
some information.
Okay, Senator Hardy.
Thanks. I am just wondering if we have put in statute reimbursement amounts in this level of detail before.
So this is for rulemaking, not statute.
Okay.
And it does allow the commissioner to update the amounts.
Okay, so section
needed.
2 would basically be session law.
Section 2 is a session law provision because it's not going to the statute, but it's directing rulemaking.
Okay.
So the amounts would be adopted through rulemaking.
So similar, also that list of organizations would
Right.
not be in statute.
Right.
Okay, that's helpful to know because I was a little worried about as things change, we would have to amend the law.
Right, I mean, it would still
Yeah.
require the rules to be amended, which is its own process, so you may hear testimony from DIVA, with different thoughts on the process, whether it should be rulemaking or otherwise, but I will let them.
Yeah, then we'll have Diva come in and they may have ideas about the amount as well or how to deal with that. And it is rulemaking, so they can change it.
Would you like me to get a fiscal note from joint fiscal?
Yeah, we'll ask Nolan. All right. I can do that, keep it.
So if I could ask, was the 850 the total reimbursement, or was that, because there were several lines, I wasn't quite sure, one was a total and one was a detail?
Right, it seems like, and I will be candid that I did not draft this bill, so we're happy to do some clarifications if you move forward with it. But it does say, it suggests that the coverage available would not exceed $850 with the allocation as set forth.
It could be that also that, this is primary care. It could be rather than fee for service, it is a, global payment, payment per member per month kind of thing. It could be just paying for the patient a total amount and then having it distributed. So that's a question. Again, it's a question for Medicaid and how that might happen.
Right, there are certainly other ways to allocate the funding.
Yeah.
And then I don't know if the sponsor or any of the subject matter experts in the room know how many Medicaid births are there in a year, just to start getting our head around the cost.
Well, I don't know that
I did
any
have this
of
off the
these,
top of my head just a few days ago.
is it,
It's,
Department of Health has it.
it's like
Yeah.
600, does that sound right?
A rough number.
Oh, okay, Elena's got it.
It is Medicaid 2,000. That's what I was thinking, I
Oh,
saw it
okay,
with the
yeah.
treasurer's thing.
2,000.
2,000,
right.
maybe 600 was.
That's right, in the baby bonds.
Yes, exactly.
Good connection.
What about the accessibility? How many doulas are there in?
Well, these,
Vermont?
these are really good questions that we'll have to ask. We'll get some testimony in, and maybe Martine, you can help us, Senator Bullock, you can help us get a list of folks to testify in addition to Medicaid.
Mm-hmm.
15 minutes ago, he issued a press release.
In the
that-
process of testimony, would be very interested in the opinion of OBGYN community.
Oh, yeah,
Because I
absolutely.
just don't,
Yeah.
it's not a concept.
Okay, sure, we can do that.
Yeah, and I just wanted to add, I do think that has now been drafted a few years ago, so I do think the numbers need to be updated on the amounts. And also, I know there's some questions about the training piece, so we'll have to get into that as well.
Yeah, so finding out, that in addition to having doulas in, who are practicing, we'll have to talk with someone who's familiar, as a part of the registry or some
Yeah.
administrative person, yeah, good. Okay, so we have a lot of questions, but it sounds interesting, right? Something we want to look at. Okay,
Yes.
now you know what to do with this.
I do.
One thing I'll just add
Call them
on doulas, it's, I think Senator Martine, Senator Gulick mentioned this, a little bit, but, the health equity, impact of this
Yeah.
would be huge. There are a lot of states who are trying to create a package of new laws that would help, especially Black women in childbirth, because they are significantly more likely to die during childbirth, and doulas are one really low-cost way to help help with the equity issues surrounding Black women in childbirth. So
Well-
that's another really good reason to do this, because the numbers are staggering.
Thank you for bringing that up.
And you're right, and so in particular in your district, there's a number of folks who really rely on doulas and one another for birth rather than more medical.
Right.
Yeah. Used to be my district. All the way.
Sorry.
Okay. Okay, so we'll move along on that one. Thank you. Thanks for bringing that in. And so now we're gonna move on to S211. And just by way of explanation on S211, the more you get involved in all of the what we qualify as healthcare reform, we understand that there's a need for some systems improvement and changes since the Green Mountain Care Board, for example, was established as a board that oversees, was looking at and planning for single payer. And now we don't have that, but what we do have, we have disparate elements of a system that are in some ways not aligned. And so one of the goals for Act 211 or S211 is to begin to look at alignment and to bring things together. So establishing a broader opportunities for data analysis, for clinical improvement, and looking at quality improvement, and combining more patients into the larger data pool so that more informed decisions can be made about moving clinical improvements, so improving quality. Some of this is a little bit about access. Some of it is about redefining the board. And some of it is about hospital budget making. So elements of the whole system to try and offer improvement. The bill is a beginning. So we'll hear testimony, and as Jen goes through it, it will seem like this one doesn't seem connected with that one, but in reality, there are a lot of little gaps in places that we're trying to identify and improve the system. The S151 that we looked at the other day has some sections in it that we would like to, I think we talked about some, like the gold card section and a couple other sections that we may want to transpose and put into this one. And there's one section in there that is already state law, a very controversial section that we've heard a lot about. And I think we'll just let that one sit on the side for now, unless I hear differently from anyone in the committee. So what I'm going to say about S151 is that I'm going to ask Jen, work with Jen to identify some sections in that bill that we might bring into this bill. So please do go back through 151, and if you see something that you really like, let me know, and let her know, and we can take time to do that in committee if you prefer. Then, but then getting back then to in total, the 211 is, it's an important time for us to realign all the elements of the healthcare system, whether it is public-private insurance, whether it is how we're moving ahead with all-payer model, what's happening with ACO, if at all, what is happening with an integration of data for quality and other improvement, and most importantly, how are we building some equitable reimbursements in the system, because equitable reimbursements should ensure sustainability for all of the primary care docs that we're losing, especially in the rural parts of the state. So there's a lot of things that are in the bill after talking with folks. I did spend a lot of time talking to a number of people on this, but and not all the ideas in here are my ideas. Some of them are, some are others. So the whole polyglot, right? Little soup. So we'll go through the bill and we'll see what's there, and then ultimately, I know that people in the room now who have a great deal of interest and expertise, including private insurance, including Green Mountain Care Board, including hospitals, including patients. So we'll see, and including our DAs and our SSAs. Good. So Jen, why don't we go through the bill? Great.
Put it on the screen. This is S211, and it is an act relating to healthcare reform and to the regulatory duties of the Green Mountain Care Board. So the first section, and by way of explanation on the order, it is in order, numerical order, starting with the lowest number title of the statute. So things seem to jump around a little bit, that's why. So the first section is amending 3 VSA section 3027. This is the section that of existing law that deals with the Director of Healthcare Reform and the Agency of Human Services and their responsibility. And this would add a number of provisions. The first one specifying that their responsibility for coordinating healthcare system reform efforts among various parties includes engaging in payment and delivery system reform to the extent so directed by the General Assembly. And then we have the Director of Healthcare Reform in consultation with the Green Mountain Care Board and the Department of Health, developing and maintaining a method for evaluating system-wide performance and quality. And that concept is really moved over from the Green Mountain Care Board statute. So you'll see later on that that is crossed out in some of the Green Mountain Care Board statutes and moved over to the Director of Healthcare Reform. New language is including identification of the appropriate process and outcome measures for a list of things. So for determining public and healthcare professional satisfaction with the health system, for utilization of health services, adding consultation with the Director of Blueprint for Health is looking at the quality of health services and the effectiveness of prevention and health promotion programs. For cost containment and limiting the growth in healthcare expenditures, for determining the adequacy and supply of health care resources in this state, and to address access to and quality of mental health and substance use disorder treatment services. Those are all moved over from the Green Mountain Care Board statute, and then the next two are new. So for including population level clinical data to measure population health improvements, and for providing the information to the Green Mountain Care Board to inform the board's regulatory work, its decisions regarding health insurance rates, hospital budgets, and accountable care organization certification and budgets. Also for improving access to care through care coordination between providers and services, such as between hospitals and residential or long-term care services, between primary care and specialty care, between primary care and access to mental health or substance use disorder treatment services and recovery services, and then the catch-all of other measures determined by the director.
1 through 5 is moved over, is that?
1 through 6 is moved over from, you'll see it crossed out later in the Green Mountain Care Board statutes.
Okay.
Section 2, this is a provision that I believe is also in S-151, around insurer participation in multi-payer alternative payment models. This language specifies the intent of the General Assembly first to provide commercial health insurers in the state with the opportunity to participate in Vermont's multi-payer alternative payment model or models established under the state's agreement with the Center for Medicare and Medicaid Innovation. But if no insurers elect to participate in the model or models, then the Department of Financial Regulation shall require insurers to participate in the models as a condition of doing business in this state. And this is language that is modeled on or similar to language on insurer participation in the blueprint, which has been in place for a number of years now. Section 3, now to orient you, we are in the Green Mountain Care Board chapter. And the first section that's amended is the purpose of the Green Mountain Care Board. So it continues to say it is the intent of the General Assembly to create an independent board to promote the general good of the state by, and then changing the wording on from improving the health of the population to making decisions that improve population health. Adding language in the reducing the per capita rate of growth and expenditures for health services in Vermont across all payers, to tie this to the board's work in regulating health insurance rates, establishing hospital budgets, including global hospital budgets, under the appropriate reference there, and certification and regulation of ACOs under section 9382 of this title, while ensuring that access to care and quality of care are not compromised. And I would strike out a few provisions dealing with experience of care for patients and providers, recruitment and retention, high quality healthcare professionals, and achieving administrative simplification. But some of those concepts are pulled into this new, what will be subdivision 3, aligning payer policies, administrative obligations, and clinical services to reduce administrative burdens, establish and approve equitable reimbursements, and ensure clinically appropriate care coordination and continuity of and access to high quality care.
Is it possible just to pause for a few seconds while I take
You
this?
digest.
Yeah.
So
Thank
that's
you.
a request of the veg council, for your veg
I
council.
appreciate that.
Yeah, it's good. So Jen, yeah, take, maybe, slow the pace a little bit.
Okay.
A lot here.
Anybody?
Okay, and, somewhere, no, in 151, there is a section on the Green Mountain Care Board nominating process, so somewhere off into that bill. So,
Sure, Jen, we can
Yeah.
take whatever provisions you would like from them. Section 4 is amending a couple of provisions in the statute on the Green Mountain Care Board's membership and authority. So the first would be to delete a provision that allows the board to delegate responsibilities to members, officers, and employees of the board. So the existing language that is struck would say, except for final decisions in regulatory matters over which the board has jurisdiction, a member of the board, board officer, or board employee may perform any service that is within the board's jurisdiction and that the board delegates to the member, officer, or employee.
I guess the chair can probably do this anyway.
I think a lot of that
Yeah.
happens,
Kind of,
but you may want to hear from
right.
folks about what's.
So what is the impact of this?
We'll hear from the board, whether that has an impact.
The next change at the top of page 7 is to strike language that's, oh, I'm sorry.
It's kind of a good question. So what's the genesis of this bill? What are we solving from a 40,000-foot view?
Yeah, from the 40,000-foot view, we're trying to correct some of the glitches that we see within the system, the healthcare system, and to move ahead with reform. So right now, there's not a lot of alignment, for example, between public and private insurers. There's not a lot of alignment between, there isn't a lot of, there's inequitable reimbursement. And so trying to sort out how to improve that. The board has a huge set of responsibilities that extend from developing rules, developing plans, and then helping to implement those and then regulate them. So it's sort of the horizontal and vertical integration that we see that is really one board doing everything. So trying to separate out some of the roles that folks would play. Department of Health, right, has a lot of equipment for collecting data and building an analytic system. And the Director of Healthcare Reform is sitting over in AHS, and then we've got healthcare reform over here. So we're trying to pull things together. This is not the last word in the bill. We're going to have to hear from the board and from everyone else who's part of the whole system, and sort out what actually we can do this year or not. So it's, yeah. The genesis of the bill, I will take responsibility for that and for reaching out and talking with different folks about what would help to improve the system. So not everyone agrees on all the pieces that are in here, that it's helpful. And so you're going to hear disagreement, and that's fine. That's part of the process. But there are also some things that, we may have to align up a little bit more than we are right now. We may have to improve reimbursement to ensure that workforce stays in place. We may have to make those connections. So that's some of what the bill does. Just me, I'm sorry.
My question.
Right.
Go ahead.
So if you don't mind me asking, when you use the pronoun we, is it the legislature? Who's the we in the?
Which way? The way, when we look at this bill, us.
No, when
Well,
you, in your response to Senator Weeks's question, like what problems is solving and what are, like.
Okay, I can say I see problems,
Oh,
but then when I talk with other people, they also see problems. And they might be different from the ones I see, but and so it is, there's an iteration of problems. Yeah,
So I guess this is a Jen question, but, so if this passes as written, does that mean that there's an act that created the Green Mountain Care Board that's gonna have to be rescinded or
no,
amended?
enough, well, they'll change, if we put in the nomination process, that would change. If we put in some changes to what they do with data and how they collect it, that would change. And that would have implications for the board, there's no
Right.
question about it.
Right.
Yeah,
Right, so this is amending some of the statutes that created and have been amended since the board was first created in legislation in
2013.
2011.
was it 2011?
This is when the legislation, Act 48 was what
Seems like
created.
yesterday.
So, yes, so
Okay.
we would be amending, if you passed it as written, you would be amending certain statutes that relate to the Green Mountain Care Board.
So I assume that some of this will come out, certainly will come out in testimony, but I'm just curious about, does the Green Mountain Care Board, have they been involved in this drafting process?
Part of it,
Okay,
and other people have been involved in other parts of it. So there are parts that they like and parts they don't like, parts that I like, parts I don't like, so on and so forth. So it's a mix. It's an opportunity to go through and sort out and compromise and collaborate, which is what we should be doing.
yeah, good.
Senator Weeks, I think it's fair to say that there's not full agreement on this bill. This is the first time I've seen most of this language, and I'm not sure it would realign things as a way we would like to in every case. So
Well,
I'll be interested to hear the
We'll find out about that, Senator. And the fact of the matter is that there are folks who've been involved in healthcare for many, many years who have contacted me and asked me to add some of these things and to consider them. So it's not, there are a lot of people in this state who've been keeping an eye on what's happening. And there's a lot of concern about how can we keep moving forward without dropping people by the way, or dropping providers by the way. But anyway, and we're seeing it.
That background's very helpful.
Okay, good.
Yes.
Go ahead.
All right, so on the top of page 7, this is also in the Green Mountain Care Board membership and authority. This is striking language in existing law that says, that's permissive language. It says, to the extent funds are available, the board may examine on its own or through collaboration or contracts with third parties the effectiveness of existing requirements for healthcare professionals, such as quality measures and prior authorization, and evaluate alternatives that improve quality, reduce costs, and reduce administrative burden. So the effect of striking this, as I read it, would not be to prohibit them from doing that because it is permissive language, but it's not specifying it in statute as a specific option.
Can you explain permissive language?
So instead of, often when we write statutes and you want the board to do something, you say the board shall do this.
Okay.
This says, to the extent funds are available, which is already a little
Okay.
less strict, and then it says the board may examine.
Okay.
So, right.
A lot
Permissive
of
but not a
qualifications in
requirement.
that.
Exactly, a lot of
Yeah.
qualifications, not a requirement.
I don't know where that recommendation came from. Yeah,
Section 5, do you have a question?
I do.
I do.
But by taking that language out, does that mean they cannot?
I would not read it that way. The statutes would be silent. So if you wanted to actively prohibit something, you would need to actively prohibit it.
Okay.
I mean, I think you can draw an inference about what may have been intended, but that's not a clear indication of legislative intent, just to strike particularly permissive language.
Just curious if somewhere else in the draft bill that responsibility is shifted to somebody else in these 31 pages, or if it's just striking that review, the effectiveness review, just striking it, or is it or is it shifted to another?
I don't think it's
agency?
just,
I mean, I think a little bit of both. It's right now, the language is talking about the effectiveness of existing requirements for healthcare professionals. There is some language in what was shifted over to, I think, the Director of Health Care Reform, looking at is there something, healthcare professional satisfaction with the healthcare system. You could look at it, as fitting somewhere under there. There are other provisions, I think, some of the idea of looking at the healthcare professional experience of practicing in this state is moving over to the Director of Healthcare Reform.
so S-151, I think, has language on contracts in it as well. I'm trying to remember if we did put it in there, but we'll look.
I think it may. All right, so now we get to section 5, which is amending the Green Mountain Care Board duties statute. And so it makes not a lot of changes, but a few changes in the list of duties here. The first is adding collaboration with the Director of Healthcare Reform to the list of the board's duties. And in this first one about overseeing the development and implementation and evaluating the effectiveness of healthcare payment and delivery system reforms, it takes out language referring to payment reform pilot projects, which you're going to see in a couple of pages get struck out. The whole section pretty much gets struck out. So this is, at this point, more of a conforming change to reflect the repeal of that payment reform pilot language. Under this existing duty of overseeing development and implementation of reforms, and implementing by rule methodologies for achieving payment reform and cost containment that may include the participation of certain payers. Currently, the law says just participation of Medicare and Medicaid. This would add commercial insurance. Also, in existing law, there is a requirement that the board work in collaboration with healthcare providers to develop payment models. This would add in the Director of Healthcare Reform as another collaborator to develop payment models that preserve access to care and quality in each community. And this would add, and that provide for equitable reimbursements to providers.
If I could ask, because we've had a bit of a blur of subject matter experts coming back into committee, and is the director or the representative of the director of the healthcare reform agency?
Wendy Traxton.
Wendy Traxton is not here. She's the one you heard from yesterday on the AHEAD model.
Yeah.
Okay,
She
very good.
testified yesterday, yeah.
Yeah.
Traxton.
All right.
She's probably online right now. We don't know.
All right. Also, small change on line 17. Under existing law, it was prior to the initial adoption of the rules that the Green Mountain Care Board was directed to make on methodologies for achieving payment reform and cost containment. Existing law says prior to the initial adoption of those rules, the board is supposed to report their proposed methodologies to this committee and the House Committee on Healthcare. This would strike out initial, so this would have more ongoing reporting to this committee if the board is adopting rules dealing with those methodologies. No changes to existing law on page 9. Page 10 strikes the duty of the Green Mountain Care Board to review and approve the Healthcare Workforce Development Strategic Plan, which is an existing duty of at least working on that and maintaining that as a duty of the Director of Healthcare Reform. Further on down the page, in the existing duty for the board to review and establish hospital budgets, this adds a reference to global budgets, so including global budgets under Chapter 221. And then on page 11, we get this list that's all struck through. This is what was moved to the Director of Healthcare Reform in section 1 of the bill. So this will develop and maintain a method for evaluating system-wide performance and quality. this list was of A through F, and then the catch-all, and G were all moved to Director of Healthcare Reform with 2 new provisions as well in section 1. And instead, this is engage in payment and delivery system reform to the extent so directed by the General Assembly or in collaboration with the Agency of Human Services. So this would have the Green Mountain Care Board not having an independent, proactive role in payment and delivery system reform activities. It would be either in collaboration with the Agency of Human Services or as directed by legislature. Section 6 is on payments to healthcare professionals. A lot of this is existing law. And this is in part a section on allowing the board, again, an existing law, to set rates for healthcare professionals, so the amounts that they should get paid in order to have consistent reimbursement amounts. And this would add on page 13, new language allowing the board, so not requiring, but permitting the board to use reference-based pricing, site-neutral payments, and other strategies that promote equitable reimbursement and the quality of access to and affordability of healthcare services in the state, as long as those strategies are not inconsistent with the state's healthcare reform initiatives. That's it for this section. Section 7, on page 14. This is the part I was describing earlier where the payment reform pilot language is all struck through. So we struck through the reference to it in the list of the board's duties. So now under payment reform, gotten rid of pilots entirely and specified simply that the board shall engage in payment and delivery system reform only to the extent directed by the General Assembly or in collaboration with the Director of Healthcare Reform. So that's similar to the language that we looked at in the board, in the list of the board's duties. So limiting its role in payment and delivery system reform. And then we get to a couple of pages of struck language.
Is there a trigger for that? Or,
Is your question why?
yeah,
Sure.
This was a recommendation from some of the folks that were I talked with, but the other piece of this is that initially there were what are known as SIM grants. There was money available for evaluating how to move ahead with the single payer model, and I'm thinking that this came in reference to that, and so we'll have to hear testimony on this. So there are some folks who feel will be able to inform us a little more on that one.
Thank you.
Section 8 is in the board's oversight of accountable care organizations. So as you know, the board, Green Mountain Care Board, certifies ACOs and approves their budgets. I am on page 19.
So
a few pages
all
of struck
those
language.
pages are striking.
Yeah, striking that payment reform pilot.
So
Yeah.
is it, is this pilot no longer a pilot? Is it an actual thing? Is that why it's
This was
being
some
struck, or what is it?
I would want the board or others to talk to you about whether these pilots occurred. There are so many initiatives that have moved forward. I'm not sure what moved forward as a result of certain statutory provisions or others.
Vaguely, I remember some of the
Just
pilots.
trying to figure out if it's something that happened and is done and therefore getting rid of it has no impact, or if it's something ongoing that getting rid of it has an actual impact.
I'm not sure it's as cut and dried as that, so I don't have a good answer for you.
So if you look at page 15D, for example, the scope of services and any capitated payment should be broad and comprehensive, including prescription drugs, diagnostic services, acute and subacute home health services, services received in the hospital, mental health and substance abuse. So it's a very broad list of capitated payment, which might be something we should consider not taking out. But so we should have testimony on each of these going forward and understand from the board's perspective and also from the Director of Healthcare Reform perspective, what they do.
So I don't know if the board relied specifically on this section for initiatives that it has undertaken, or if this language has just sort of, there are certain provisions that were enacted anticipatorily, but not necessarily ever used, and I don't know if that was, if this is the basis for something that they have done or are currently doing and would feel the loss of, or whether it is something that has just been sort of off to the side and not relied upon.
Yeah, that exactly. Well put. Because on page 17, paragraph F, it says the first pilot project was October of 2012. So
Right.
not sure if
Those were, Susan, correct me if I'm wrong, was it SIM grants that we're talking about in there? George Maharis was
Susan
working on
Garrett,
those.
Executive Director of Student and Care Board. I recall the
Yeah.
pilots were an oncology pilot we did
Oh.
up in St. Johnsbury.
Okay.
We did a pilot study on prior authorizations with Dr. Ramsey.
Okay.
Which is really
Oh, I remember that.
impressive.
Yeah.
So we've utilized this
Yeah.
authority and it's given us the flexibility to really test.
Okay,
things.
so we'll hear your testimony, but that's all I
But
wanted
those
to
are the
know.
two that come to
Yeah,
mind.
that's good.
Immediately, I'm sure
Yeah.
there are more.
Okay.
All right, so accountable care organizations. The first piece, the first change here on page 19 would be to specify that the Agreement and Care Board's review, consideration, and approval of an application for certification or an ACO budget shall be considered the deliberations of a public body in connection with a quasi-judicial proceeding in accordance with 1 VSA section 312. What does this mean? This means that the board could conduct these deliberations without having to make all of their meetings open to the public. So it's a carve out from the open meetings law. It is similar to language. The open meeting law itself has this same concept for judicial proceedings, for proceedings, deliberations of the Public Utility Commission, and any other quasi-judicial proceedings. So this is putting these deliberations in that same bucket.
You know, the Public Utility Commission is a good model to look at for some of this.
Yes, that is what we
Quasi-judicial.
initially, when drafting the Agreement and Care Board
Yes.
language 13 years ago, we looked a lot to the public,
Right.
and public service board, but Public Utility
Yeah.
Commission. Yes, so.
Well, I just wanted to say, as chair of GovOps, this would need to go to GovOps because we are actually doing a bill right now that revises the open meeting laws. And so I want to make sure this is consistent with what we're doing down the hall.
Could look at that section for us,
Yeah.
that'd be great.
Yes, and so the language in 1 VSA section 312 says, which is the open meeting law, which is entitled Right to Attend Meetings of Public Agencies, says everything needs to be public and warned in accordance with specific time periods. And then it says nothing in this section or another section right after this one shall be construed as, so nothing in this open meeting law shall be construed as extending to the judicial branch of the government of Vermont or of any part of the same or to the Public Utility Commission, nor shall it extend to the deliberations of any body in connection with a quasi-judicial proceeding.
Okay.
So that's where this language comes in, is to say this is like a quasi-judicial proceeding. And you'll see the same language come up in the context of the hospital budget review as well. Then there's a new provision added at the end of the ACO certification and budget review statute, directing the board to adopt rules to establish standards and processes for certifying Medicare-only ACOs, so those ACOs that are only receiving payments from Medicare, in order to, in determining whether to certify a Medicare-only ACO to operate in Vermont, the board may consider as many of the criteria in the subsection A, the long subsection on what they consider in certifying other ACOs as the board deems appropriate to a specific ACO's size and scope. Section 9 would enact a new section in 18 VSA chapter 221, which is on healthcare administration, regarding termination or non-renewal of a health insurer contract with a healthcare provider. This would say at least 60 days prior to the termination of a contract between a healthcare provider, including a facility, and a health plan, commercial health plan, the parties must utilize the mediation services of the Green Mountain Care Board to assist in resolving any outstanding contractual issues. It also says that the results of the mediation would not be binding on the parties, so non-binding mediation. Section 10 enacts a new section as well on alignment of credentialing, quality measures, and data collection, requiring each health insurer and Vermont Medicaid first to credential and enroll any healthcare provider who is credentialed and enrolled in Medicare. They're credentialed and enrolled to participate as a participating provider in Medicare. They would have to be credentialed and enrolled in insurance plans and Vermont Medicaid. A health insurer shall not require a healthcare provider to engage in or report on quality measures other than those used by the Centers for Medicare and Medicaid Services. And a health insurer shall not require healthcare providers to collect data other than that collected by the Centers for Medicare and Medicaid Services.
So this would only apply to health insurers, not to the state, because we sometimes ask people, providers, to give us data that's maybe beyond what is.
We can still do that. I mean, the
Right,
legislature.
this is about what health insurers
Yeah.
Okay.
can do. And you could not actually
Senator
restrict.
Willis,
So
go ahead.
back
So,
to
future legislature.
We're going
Yeah.
back.
line 6,
Yes.
says, is that a federal requirement or is that something specific to this bill?
This would be something specific to this bill. This would basically deem whatever credential and enrollment process Medicare has engaged in as sort of by definition sufficient for insurers and.
Is that
Medicaid.
normal? I mean, they normally do that?
Well, it lines people up.
Right,
Yeah,
so
makes
no,
it more predictable.
it is not what currently happens.
Okay.
So this would be new.
Okay.
Something to
And you
talk
may,
about.
right, and you may hear from, you will hear, I'm sure, from insurers and Medicaid about what they think about it.
I'm sure.
Oh, yeah.
Okay.
I may have a 2-page bill when we finish.
Section 11 amends the hospital budget statutes, actually starts a couple of sections dealing with hospital budgets. So the first is what hospitals' duties are. Hospitals have to file certain information as part of their budget review process, file certain information with the board. So this would add, first on the top of page 21, in addition to scope of service and volume of service information, it would also require aggregate data on provider productivity, which is a sort of a measurement of how effective, how productive providers are, depending on the specific metrics used. Also, in number 7, salary information for the hospital's executive and clinical leadership and the hospital's salary spread. So this is language similar to what the board is already required to consider, but this puts the affirmative duty on the hospital to report it so that the board can consider it. And then small but big change on line 12 would change the hospital fiscal year from beginning October 1st to beginning July 1st.
So just a comment on this one, because this isn't an easy thing to do. It's difficult, it take time, but right now, the insurance rates are established before the hospital rates, and it seems backwards, and we've heard from folks that that's backwards. So if we put the hospital budget decision first, then we know what the insurers have to. So we'll hear testimony on it, but that's what that does. And it isn't going to be an easy flip, I think, for that to happen, but we'll see.
I wonder, and we'll hear this in testimony, but if it would have an impact because of the federal fiscal year starts on
Yeah, of
October
course, it does.
1st,
That's
which is
part
when
of the
most money
flipping
comes
process.
in.
Yeah,
Yeah.
yeah.
All right, so that was what hospitals have to do with respect to their budget review. Section 12 is the board's role in hospital budget review. And the first piece of new language here is this same language that we looked at in the ACOs about the deliberations being considered the deliberations of a public body in connection with a quasi judicial proceeding. So this is the other open meeting law exemption provision. Then in conjunction with budget reviews, the board has to do a number of things. So review utilization information, and this adds also reviewing that aggregate data on provider productivity that the previous section required the hospitals to provide. This would add a specific duty to consider the quality of, access to, and affordability of the services provided by each hospital. And then renumbers everything else after that. In what would now be number 4, where the board considers the expenditure analysis for the previous year and the current year. They would also have them evaluate and consider spending across sectors of the healthcare industry, including primary care, mental health care, long-term care, hospitals, independent specialists, and substance use disorder treatment. And then everything else gets renumbered. And we have on page 24, so no changes on page 23 except to renumber. Page 24 would say if the hospital is part of a hospital system, then the board would need to consider the role of the hospital in the hospital system when evaluating its performance, financial stability, and internal allocation of resources.
Can we pause there for 1 second? Okay.
And remembering cross-reference. On top of page 25, this makes those same changes around the timing of the hospital budget review. So now instead of the board establishing the budget by September 15th, with a written decision by October 1st, the board would establish the budgets by June 15th with a written decision by July 1st. Then subdivision 2 would specify that any hospital revenue connected to a fixed prospective payment arrangement would not be considered as part of a hospital's budget for purposes of the board's review. So carve out this fixed prospective payment arrangement money that comes in.
So is this payments from, at this, for example, at this point, one care payments?
I'm not sure what,
We'll have to see where it's coming from. That's the question.
I'm not sure I can. All right, on page 26, there's some additional language added. So in existing law, the board may establish a process to define on an annual basis criteria for hospitals to meet, such as utilization and inflation benchmarks. That's existing law. This would add new language saying that any such criteria or benchmarks should be set at the hospital level or across the healthcare system and not at an individual cost center or service level. So these are sort of larger level criteria and benchmarks. And that the board must consult with stakeholders prior to establishing these criteria or benchmarks. Criteria or benchmarks must be established not later than March 31st annually, and that they cannot be adjusted or amended during the budget process except by mutual agreement of the affected parties. All right, that is it for hospital budgets. On page 27, section 13, we're now moving to the Board of Nursing. And this would direct the Board of Nursing to adopt rules to establish a student nurse apprenticeship program, including eligibility for the program, the scope of practice for student nurse apprentices, and board issuance of student nurse apprentice permits to eligible nursing students.
So
this
the
would
board referenced here is the Board of Nursing.
Yes, it's the Board of Nursing. And so this would allow student nurses to be delivering services as a student nurse apprentice while they're still in training. Section 14.
Sorry, that's helpful to know. This is the Board of Nursing.
Yeah.
As we're moving around boards. I'm wondering if this is something that's already happening and that they're trying to make sure that it's,
I don't think it is. I
Okay.
think this is something, I mean, there may be a way that they have people practicing, or doing, I mean, I know they do preceptorships.
yeah, because
in-
exactly.
right, But I think this is different, and I know some other states, I want to say Alabama does
Yeah.
student nurse apprenticeships, and there may be others, so I know there's been
I hope
interest in
there's
this.
others.
I think there's, standalone.
Yeah, Alabama wouldn't be the first one to
Okay.
say that.
All right, section 4, speaking of training, this is training for the Green Mountain Care Board. So this would direct the Secretary of State to provide or arrange for training for members and staff of the Green Mountain Care, it should say board, on Vermont's open meeting law, on conduct of contested case, including appropriate decorum during hearings and other public meetings, and other topics that the secretary thinks are appropriate for the proper operation of a governmental board. The training would be provided to newly appointed board members and at such other times as the board chair may request.
So where is this coming from?
Me. I'll tell you where it came from. I'm very disturbed by some of the publicity and language that I'm hearing when a board meeting is carried on, and we had a harassment training the other day, and we were learning how to work with witnesses and others who are before us, and I'd like to extend that kind of training to the board. We also know that when board members are appointed, they may not have experience on a board, so it's good to have some kind of orientation formally in place for board members so that they can become accustomed to being on a professional quasi-judicial regulatory board. That's all.
Are the other quasi-judicial regulatory boards
No
required to do this kind of training?
I don't know whether PUC does it or not. They haven't had turnover, so I don't know what the tradition is there.
Not statutory language, because
No.
Okay,
came up.
I mean, again, I think this is a GovOps issue, because this is really not consistent with other
Well,
boards.
we can talk and find out whether it's consistent, and then the need for it, from my perspective, there's a need for something and to make sure that the board maintains its professionalism. That's all.
I think that the board has always maintained its professionalism. They ask tough questions of hospital executives, and that's okay, that's their job.
Right, so we can talk about that, but for me, it's not the questioning that's the problem. So we can talk about that.
All right, page 28, section 15. This would direct the Agency of Human Services, Department of Financial Regulation, and Green Mountain Care Board to collaborate on a joint plan to implement population-based hospital budgeting that is based on an actuarially determined rate of growth designed to ensure hospital solvency and stability, and it may serve as a model for future payment reform initiatives. And it says the plan may include one or more of the following. May include creation of a unified, comprehensive data source that supports both attribution and measurement of per capita costs in various populations. It may include use of geography-based attribution enhanced by person-level information. It may include selection of a geographic unit for attribution. May have separate attribution of populations by type of care. May include development of one or more mechanisms to attribute the portion of the population in each geographic unit whose use of hospital care is at other than the dominant hospital. May include establishment of an initial budget, and it may include establishment of methods to project expected cost growth and the setting of an allowed growth rate. So we have a progress report on how the plan development is going by September 30th to the Health Reform Oversight Committee, with the joint plan submitted to this committee and House Healthcare Committee by January 15th of next year.
How is population-based hospital budgeting different than global budgets? What?
Based on the population that you're caring for and what the needs are, so you could have a different cohort depending on which hospital and the types of patients you're looking at.
But does this conflict with global budgeting? Because it
No,
seems.
global budgeting would be, and we'll ask that question, but it would be the percentage of increase, for example, that one gets in a budget, and you get a set amount, and you have a range within which you meet your budget each year. This is more looking at what's needed within the populations being served.
Section 16 would have the Green Mountain Care Board in collaboration or consultation with the Director of Healthcare Reform evaluate realignment of the timing of the board's regulatory processes. This evaluation would build and expand upon the board's regulatory alignment efforts and may include considering alternative models such as multi-year budget reviews, multi-year financial stability audits, and other regulatory processes that achieve the state's goals of improving the health of the population and reducing the per capita rate of cost growth while ensuring access to and quality of health care. Have the board report its findings and recommendations to this committee and others by next January 15th. Section 17 directs the Office of the Attorney General in collaboration with the Green Mountain Care Board to develop joint legislative proposals for appropriate review and approval of mergers, affiliations, and divestments involving hospitals, clinics, independent practices, long-term facilities, and other healthcare providers located in Vermont by the Office of the Attorney General or Green Mountain Care Board or both. On or before December 15th, the Attorney General's office and the board would provide their legislative proposals to certain committees, including this one. And finally, we have section 18, which is another study and report with the Director of Healthcare Reform in consultation with interested stakeholders, developing a proposal for a single entity in the executive branch, such as the Department of Health, to be responsible for establishing and maintaining a system for collecting and integrating clinical healthcare data. The system would be designed and implemented in collaboration with the Director of Healthcare Reform, the Green Mountain Care Board, the Blueprint for Health, the Vermont Program for Quality in Healthcare, Vermont Information Technology Leaders Vital, and other entities that collect clinical and claims data. So the system would collect and integrate the data from sources including the Vermont Health Information Exchange, VCures, Accountable Care Organizations, and VPQHC in a manner that allows the data to be made accessible for analysis by provider type and to be used for bundled payments for clinical improvement as determined to be appropriated by healthcare providers and for other purposes in keeping with monitoring and improving population health and health outcomes. Finally, the effect of,
Is this trying to find a place for data collection that is now being allegedly done by the ACO?
No, it's being done by VPQHC. There's clinical data at Vital. There is private insurance data, and this would pool as much as possible so that you could understand clinical improvement by patient type.
I recall that we did something in Act 167 regarding kind of consolidating data. So
We did.
I would
there
love
was
to hear
some, but
where.
I think by the time it came out of this, or out of the legislature, it was more sort of a continue your efforts to come up with a consolidated source.
Yeah.
All right, finally, we have the effective dates. The act would take effect on July 1st of this year, except that the provisions dealing with hospital duties and the Green Mountain Care Board duties for hospital budget review would take effect next January 1st and apply to hospital budget reviews occurring on and after that date. So not for the hospital budgets that are coming up fairly soon after passage of this act.
If it's possible to get there that quickly. So this is a long bill, and there's a lot here, and we have a lot of people who have a lot of interest. What I'm going to suggest two things because we have time. First, I'm going to say that we take a little break. That's one. Then I'd like to come back and go through go through S-151. Jen, can we do that briefly and identify maybe the sections of 151 that we feel we could merge with this? So we're doing that together. We have time to do that together. And then if we have, depending on how much time we have, I'd like to go back through 211 and maybe look at some of there's a whole host of strikeouts in here, especially on page 14. So maybe go through some of the specific, just go through it a little more with more specific.
I'm available until 11.
Okay, we can do that. So, oh shoot, let's take a 7-minute break. We'll come back at 25 after, please. We'll do that. And then we'll go through 151 and see how far along we get.